Good afternoon, everyone, and welcome. Thank you so much for joining us. This is Tracy Morton at the National Rural Health Resource Center, and thanks for taking some time out of your schedule today to join us for the first TASC 90 webinar for the FLEX program year. Today's topic is a great one. We're going to be doing an update on the rural transition to value models, and today we'll be focusing on learning about what the Center for Medicare and Medicaid Innovation, or CMMI, is doing with the state innovation models, or SIM models, in their rural activities. We'll also be learning about tools for critical access hospitals to use to demonstrate value and to participate in the alternative payment models that are rolling out around the country. So today we'll start with a brief update from myself here at the Technical Assistance and Services Center, or TASC, about what's going on in TASC, and an update for the for the FLEX program. We'll then be joined by Joaquina Scott and Sarah Young from the Federal Office of Rural Health Policy at the Health Resources and Services Administration, who will provide a critical access hospital regulatory update and an F4HP update. Then Neera Agarwal from the Office of Information Technology at HRSA will be joining us to provide you with an update about some changes that have recently been made to the electronic handbooks homepage. And then lastly, we'll hit on the topic for the day, which will be that update on the rural transition of value, where Keith Mueller from Brupri Center for Policy Analysis and the Rural Health Value Team will be talking about some of the updates that they're seeing with the SIM models nationally. And Sarah Leahy with the Colorado Rural Health Center will talk about the work that's happening in Colorado related to the SIM program there and iCare, and how it's touching on the rural programs and the interaction with their state FLEX program there. So without further ado, a brief TASC update. We ask that all the state FLEX programs please save the date for the 2017 Federal FLEX Program Reverse Site Visit. The site visit will be July 19th and 20th in Bethesda, Maryland, so we look forward to seeing everyone there. If you're interested in participating in the planning committee, please RSVP to Nicole Clement by next Wednesday with your interest. There'll be 2 calls for the planning committee, and we do ask that you try to participate in both calls if you're interested in doing so. The calls will be Tuesday, November 22nd and Tuesday, December 20th, and both calls will be from 3 to 4 p.m. Central Time. And what the planning committee does is we review what happened last year at the reverse site visit and kind of debrief and think about some new opportunities for this next year, as well as look at some feedback from all of the state FLEX programs, so what topics they'd like to hear. And the planning committee really helps to set the theme for the conference, as well as the structure of the agenda, and helps to identify some potential speakers. If you're not interested in participating on the planning committee, but do want to share your thoughts about topics, there was an assessment, an electronic assessment that was sent to everyone from Nicole Clement on Friday, November 4th. And we please ask that you just respond to that assessment on what topics you'd like to see at the reverse site visit. That assessment and the opportunity to respond to that will close on Friday, November 18th. So please take a few minutes to respond to that. A couple upcoming items as well. There will be a Medicare Beneficiary Quality Improvement Project, or MBQIP, virtual knowledge group call for state FLEX programs and MBQIP subcontractors on Monday, December 5th from 1 to 2:30 p.m. Central Time. And lastly, TASC will be launching some monthly virtual knowledge groups coming in December on a variety of different topics. And so look for a message coming soon about that, and we look forward to sharing that with you. So now I'm going to transition things over to Joaquina Scott and Sarah Young with the Federal Office of Rural Health Policy for the CH regulatory update and the F4HP update. Welcome.
Thank you, Tracy. Can everyone hear me okay? Can you hear me, Tracy?
Yep.
Okay, great. All right, so I'll just provide updates on several final rules that CMS has published since the last call. The first being the emergency preparedness requirements for Medicare and Medicaid participating providers and suppliers. This rule goes into effect November 16th. However, providers and suppliers have about 1 year till November 16th of next year to come into compliance and to implement the requirements. For critical access hospitals, I just note that they too are required to implement the requirements under this final rule, similar to other hospitals, including having a communication plan that includes information for other critical access hospitals and or hospitals in their area, documenting the name and location of the facility or other location for patients who leave the facility during an emergency, complying with generated testing requirements, as well as having a plan for how to keep emergency power systems operational during an emergency. And so I provided a link to that particular rule so that you can, for further information for that rule so that you can look a little bit more closely at what some of those requirements are as well. For the physician fee schedule that was recently published, I wanted to just note that they did add a couple of services for telehealth, including services for advanced care planning as well as end-stage renal disease services. Another thing to note for this particular rule is that they're implementing a separate payment for behavioral health integration, which will allow for care by a primary care team that has both primary care as well as behavioral health specialists to address behavioral or substance abuse issues with beneficiaries. Also of note is a new diabetes prevention program, which really starts in 2018. So CMS is rolling this out effective 2017 that will allow basically providers and suppliers to pretty much prepare for participation in this program. Part of being able to participate is that providers, including physicians participating at hospitals and working within critical access hospitals, providers have to basically have two types of eligibility requirements. One, they have to be certified by the CDC as being able to provide this diabetes prevention program, and they also have to be a Medicare provider. So CMS actually left a lot of details out about how payment would be done for this new program, and they plan on providing further details about how the benefit itself as well as how providers can be paid under this new particular service code in 2017. Also, as many of you are probably aware of, CMS finalized the quality payment program. Of note for rural providers is that they, from the proposed rule to the final rule, they raised the threshold that would really exempt a lot of providers, particularly targeting small and rural providers. And so if you are a provider that has $30,000 or less in Medicare claims or C100 or fewer Medicare Part D beneficiaries, then you would be exempt from participating in this program. Critical access hospitals, however, those that participate for it, Method 2 critical access hospitals are expected to participate in this particular program as well. So CMS put out a, they have a new website that aims to provide that one-on-one type of technical assistance for providers as to whether or not, one, they have to participate, how they have to participate, what type of measures are most applicable to them. They provide a, the rule is, I think, is historically one of the longest I've seen from CMS. Prior to it being published in the Federal Register, it was about 2,200 pages. Now the published version is about 800 pages. But they did provide a summary, 24-page summary at a high level of some of the major policies coming out of that particular program, quality payment program. For the inpatient prospective payment system final rule, I wanted to just highlight the withdrawal of the two-midnight rule adjustment, not the rule itself, but basically the adjustment that the the 0.2% cut that CMS implemented when they implemented the two-midnight rule policy in 2014. So in this final rule here, they're basically permanently cutting that 0.2% increase for certain hospital inpatient services, as well as doing a one-year 0.6% increase to account for when those cuts took place back in 2014. So for 2017, there will be overall a 0.8% increase based off of them cutting, moving away from this particular cut. Also wanted to highlight that the IPPS rule also implemented the Medicare Outpatient Observation Notice, or what they're calling the MOON, which is something that critical access hospitals also have to provide to beneficiaries who will be receiving outpatient observation services for more than 24 hours. So that's something else that critical access hospitals have to be aware of. And for the outpatient prospective payment system final rule, I wanted to just highlight that the Flow Community Hospital adjustment continues. CMS is also finalizing implementation of the site-neutral payments. Again, critical access hospitals are exempted, but just thought that it would be a note that other rural hospitals may be subjected to policy changes. And basically what they're saying is that hospital off-campus provider-based departments will no longer be paid under the OPPS rate, but now moving forward they will be paid under the physician fee schedule rate, similar to a physician's office or doctor's office. This rule also removes the pay management dimension from the hospital value-based purchasing program as a result of a lot of the opioid epidemics, and out of concern that clinicians feel pressure may feel pressure to overprescribe pain medications. So CMS is removing that pain management dimension, but is looking for other ways to possibly capture how clinicians are dealing with pain among Medicare beneficiaries. Also wanted to highlight that we do have a new inbox, and we're here and ready to answer your questions or work with our colleagues in CMS to be able to address your questions. That inbox is ruralpolicy@hrsa.gov. And finally, I just wanted to remind everyone that it is open enrollment period now through January 31st. And what I provided in these two slides is just other resources. We do have an inbox specifically related to any questions, ACA-related questions that you may have. It's ORHP-ACA questions@hrsa.gov. So I'll just stop there.
Are there any questions for Joaquina about the policy updates? You can type them into chat if your phone is muted. I don't see any. I assume you can hear me, Tracy? Yes, go right ahead, sir. Okay, great. Hi, this is Sarah Young. I'm the program coordinator for the FLEX program here in the Federal Office of Rural Health Policy. As most of the people on this TASC 90 webinar probably already know, I just wanted to take a minute to give everybody a quick reminder update of where we are in the FLEX program right now. You've probably seen a version of this slide before, and you'll definitely see it again because it's something that I use for myself and I use to share with all of you to kind of make sure we're on the same page about where we are and the progress of the program.
we're in November of project year number 2 of this 3-year Flex Grant cycle, and we're just finishing up the PIMS reporting. So really big thanks to all the Flex coordinators who have already submitted your data in PIMS or started entering it. If you run into any questions in the next few days before the reports are due on November 15th, please don't hesitate to reach out to your project officer. We're here to help you with that. And I'm very interested from the program perspective on ways that the PIMS report was difficult for you this year or confusing, and things we could change to make it better for next year. So please both keep your data coming and keep your feedback coming. The non-competitive continuation is scheduled to be released March 21st, and then it would be due May 16th for the continuing funding for project year 3, which is the fiscal 2017 year when we're talking federal funding years. And that's where we are in Flex right now. Are there any quick questions for me about the Flex program? I noticed that Joyce does have a policy question, which is, will there be a checklist to help the hospitals do a risk assessment, referring to the emergency preparedness standards, I assume. Joaquina, are you still on the line to answer Joyce's question?
I'm actually not sure if CMS is planning on providing a checklist. Is that something that you're looking for CMS to do? Come out of CMS? Is that something you're looking for something to come out of CMS or for our office to provide by means of technical assistance? I mean, I see you're still typing, Joyce, but as something that I certainly can pass on to my colleagues as far as providing that additional guidance and resource. So yeah, so I'll note that and follow up with CMS to see what their next plans are for providing additional technical assistance and resources for hospitals. Thank you for that.
Great suggestion. Thank you, Joyce. And seeing no Flex program questions, I want to turn the presentation next over to Neera, who is part of HRSA's IT team, who wants to share a couple of updates about changes to the electronic handbook system and what you can expect on the new homepage. Neera, you may need to press *2 to unmute your line.
Hi, thank you, Nicole and Sarah, for giving me the opportunity to present the exciting news here. I am Neera Agarwal from Office of Information Technology, and I'm excited to let everybody know that we are changing our EHB's homepage. Next slide. The trigger point for the homepage change is the grantee survey feedback, which we conducted last year in FY15. Approximately 1,500 users, grantees provided the feedback. On this slide, I tried to summarize the feedback as a cloud. As you can see, it is very apparent that the users are complaining about the navigation, the user friendliness, training, and help. Those are the three biggest comments we got from the users. We further did the analysis, the data from the EHBs to show what was going on the navigation. Based on the data, the most important tab we saw was the TASC tab and the grantee tab. There are 542K hits on the TASC tab to submit the grants report, and there are 176K hits on the grants tab to review the grants folder. So we thought that if we solve the homepage problem, 80% of our problems will be solved. So we did research. We did ISSO. We looked into the ISSO standards and finally came up with the 4 dimensions for the user friendliness. Here we show the 4 dimensions. It is not just about the navigation. It is about the effectiveness, support, satisfaction, and efficiency. Everything combined together will form the user friendliness of the EHBs. For example, navigation is one portion, one dimension of the entire subject. If I talk about efficiency dimension, we categorize the things that can go under efficiency. For example, I'll touch upon 3 important items. Search. The smart assist global search under the efficiency dimension. Right now, the search is not very robust in the EHBs. So we want to implement the Google-like search implementation, where the moment you type in a grant number or a tracking number, you will be given a corresponding link so that you can directly go to that search criteria. Second item I want to talk about is under support, screen sharing. Right now, when you have issues, you call the HRSA contact center or the helpline or your project officer. You will send them a screenshot and you'll try to explain an issue. People may not understand as to how you came to this screen or through the navigation. We are introducing a screen sharing feature where you can share your screen online in production and resolve the issue properly. The third important feature is under effectiveness dimension, which is auto-save. Right now, we have not saved the pages automatically. There are huge pages that you have to enter a lot of data. For example, UDS data or FFR data. You have entered a lot of data and there might be power loss or computer shutdown. All this data is potentially lost. You have to re-enter the data, so we are trying to avoid the re-entering of the data. We are going to put a place on the main page where you log back in, which will be saved and shows up on the main screen. You can click the link and when you go to the page, the data will be that you had entered will be pre-populated. These are the improvements that we want to show along the navigation improvements that we are introducing in the next few months. Next. As a preview, we are releasing a new homepage markup. Now I'm going to share my screen. Give me a second. And here is the markup of the new homepage. So this is just a preview, a markup. This is not a real data. What we are trying to do is minimize a lot of clicks for the users. And these are new flyouts that you would see. And under each of these flyouts, there are clickable links. And for example, request for new prior approval. And if you click on the new icon, the request, it will show the FAQ related to that particular prior approval. And also you can see the videos associated with that prior approval. How to, for example, in this case, how do I change my project director? Similarly, you can go look at the other things as well. And you can go and we'll make it very easy. So the flyouts navigation will help. The other thing up here is getting started pages, getting started with EHBs. When you are a new user and you log in for the first time, or you log in after a few months, you will get this page where it will check the prerequisites if everything is set up for you or not, or if the UI is correct or the right version to use the EHB. So, which is a very helpful resource. Some of the organization important information, some of the grant application important to you will show up here as well. So extremely helpful to the new user, because when you do not come more often, then it just is very difficult what to do, what to get to. Here is my task. It'll show all the numbers are here, like for example, all the tasks assigned to you, all the late tasks assigned to you, and then due within 30 minutes. If you click on late tasks, you can go to the tasks that are due right away, and you can submit your documents and whatnot. The helpful videos are here, where you can view the videos that are relevant to you, how to do things. And then one of the Smart Assist items, which will help you navigate through step-by-step. For example, request a submission deadline extension. If I click through it, it'll tell you, you pick a grant, and then once you pick a grant, it'll say continue, it'll take you to the next step. So if you're not registered to an organization, it'll take you to the next step. So currently, you don't know what's going on, and then you are stuck and you're calling Tier 1. In this case, you can just, it'll take you to the next step if you need to register to an organization, and then you can hit continue. So things like that. I'm going to continue to do this. In this quadrant, you can also see upcoming documents where it shows the financial report which is available and things like that, what is coming up. The bottom quadrant shows the recently accessed documents, and also, as I discussed before, your previously saved documents will be also here. And then the tracking quadrant, where you can see for example, the prior approval, which was approved recently, or the progress report, the PO has requested change, or it was rejected, and things like that, so that you can very quickly access and provide information. And then the last thing I would like to talk about is in this quadrant is the favorites, where you can pin your favorite pages, and you can directly go there, your organization folder or the award list folder, and you can very quickly go there. I know I talked about very briefly about this search, where you can start typing like Google-like search, and it will show all related documents to that particular grant. So these are some of these changes that are coming up. And also the knowledge base, one last thing, which has very helpful information, topics, help pages, and things like that, FAQs, videos. So I'm going to switch back to my presentation. Okay, next slide. This is the new homepage we already discussed. Just wanted to let, yeah, we can skip this. I already presented the mock-up. Next screen. I'm sorry. Previous. Yeah. So we demonstrated in August timeframe, we demonstrated to BIPIC HAB and some of the OFAM grantees, and we received positive feedback so far. We are going to be releasing the new preview site URL to all the grantees by November the 11th for further feedback. Please note that the preview site will not have the real data, so if you see something related to your, it's just a mock-up site. So we are, the goal here is to gather feedback on the user friendliness, the UI itself. So when you get the email, please feel free to provide us feedback so that we can further enhance these sites. And then EHB will be releasing the new homepage around March 2016. I'm sorry, March 2017. I have a typo. We'll fix that. Next slide. We did next. This is the survey feedback on from the UI that we had done in July-August timeframe. And the next slide shows some of the feedback we received. Quite positive feedback. Overall satisfied with the changes that we had shown to the user at the conference, and the mock-up link that we released, we got really positive feedback. Next slide. Here is the notional timeline. The homepage navigation will be released with the help videos in February-March timeframe. The screen sharing that I talked about, where if you have problems and you want to share the screen, will be released in April. The Smart Assist Global Search, like Google-like search, will be released in June, and this is the notional timeline. These charts, presentation is available to everybody. I'm open to questions.
Thank you, Neera. That was a great overview of what people can expect to see in EHB in the coming year. I know I did a little bit of the work with you, along with a lot of other people providing feedback on that project. And we all really hope that this will make it easier for you guys as grantees
Absolutely.
to use the EHB system and report on your grant. So I do want to note that that web link that Neera showed is available if you just download the HRSA EHB homepage update slides that are in the file sharing pod in this webcast. And if you want to check it out and you have any feedback when you've had a chance to explore the preview site, what's the best way for people to provide feedback, Neera?
So thank you, Sarah. As I mentioned, and, that on November 11th, we will be sending email from EHBs to all the grantees HRSA-wide to the link of the markup site, and also the documentation, how to provide feedback. And it will be on the top right-hand side, provide feedback. So it will show you exactly how to do that. My suggestion is to wait for the EHB's email that will come out around November 11th. So we will be looking forward to that. Yeah. So absolutely, as soon as you get the email, right now you have the markup link. Please feel free to play around, but wait for the email from EHBs. That's the best way.
So the Flex program is getting a special preview. Thank you, Neera. And people who are registered in EHB should watch probably tomorrow or Friday for another EHB system email coming out with instructions for everyone on accessing this mock-up.
Yeah, thank you, Nicole.
So that'll be big changes. Thank you for joining us for this webinar, Neera. And I don't see any questions in the chat box right now, but we'll certainly encourage Flex grantees to provide feedback when we have a chance to look at the mock-up. And now let's turn it back to Nicole and Tracy for our agenda.
So next this is Caleb from TASC. Next we are joined by Keith Mueller from the University of Iowa, where he's a professor and in the Department of Health and Management and Policy at the College of Public Health. He's also the director of RUPRI Center for Rural Health Policy Analysis and chair for the RUPRI Health Panel. He has served as president of the National Rural Health Association and as a member of the National Advisory Committee on Rural Health and Human Services. I will let you take it from there, Keith. Thank you for joining us. *2 if you've not unmuted your line. Keith, we still are not able to hear you. Have you tried to unmute your line using *2?
Okay, does that work?
That works. We got you.
All right. Sorry, I hit the wrong key there, and I had to wait for you to tell me again what to hit. Okay, well, thank you for the introduction, Tracy. And I should mention that the presentation material you're going to get today comes from work of the Rural Health Value Project, of which RUPRI is a co-partner or a partner with Stratus Health out of Minnesota. And we've been working here at the Department of Health Management and Policy on summaries of what's happening with state innovation model implementation states, and that's what I'll be reporting on here today. And let me just see, do I have control of the slides now, Tracy?
You do, Keith. You should see down in the lower left-hand corner of your presentation a right and left arrow so that you can use those to advance.
Okay.
There you go.
So most of you know this, but I threw a slide in. What is a SIM, or State Innovation Model? So these are grants administered by the Center for Medicare and Medicaid Innovation that provide states with technical support and funding to develop and test multi-payer healthcare payment and service delivery models. There were 6 states in the first round who are now in their second year of model testing, and 11 in round 2 who are now in their first year of model testing. Why does this program matter for rural areas? Well, the resources are quite significant. $250 million in round 1, $622 million in round 2. You'll see in a moment that the states do include rural sites in statewide efforts in their innovation models and engage rural providers and other stakeholders who then influence the total impact of what's happening. The Rural Health Value Project is approaching this, as I said at the beginning, to summarize the SIM plans in the round 1 states only at the present time. We can chat a bit at the end. If this is of interest, we can continue to do this for round 2. What we're doing is simply presenting information about activities in the round 1 states. We are not an evaluation unit. That's being done locally by the SIM states themselves, and there is a national evaluation report that's been done now for years 1 and 2. We will continue to monitor the developments in the SIM program. As I said a moment ago, it's up to question at the moment whether we should do what you're going to hear from me today about 4 round 2 states. The first document that I'm reporting from is in draft form at the moment. We expect it to be released in early December. So the round 1 states included Arkansas, Maine, Massachusetts, Minnesota, Oregon, and Vermont. We've included 1 round 2 state, Colorado, in our early work, and not really talked much about Massachusetts. A word about the methodology of how do we get our information. There are abstracts available if you went to the CMMI website and click through to get to the state innovation models. Then you can get detailed information, which we've done from websites, some of which is still, even for the round one states, only their plans, not a lot of information about what they've actually done. So we did contact states directly to try to collect as much of that information as we could. And there are annual reports that I mentioned earlier. Fair warning, I think they average about 500 pages each because the contractor is obligated to report for each state across a series of indicators. And those are posted to the innovation.cms.gov website. So in an overview, a couple of overview slides here about what is the rural impact of the state innovation model sites. So we looked at what are their commitments to rural, looking again at the abstracts and their own initial plans. So in Arkansas, it's increasing technical capacity and the number of providers. Colorado is more extensive, with primary care transformation underway or be implemented in cohorts. You'll get the detail in a moment, in 400 sites that include 21 in their first cohort of 100. They're using an extension model to collect medical practices with local resources. And you may hear more about Colorado from Sarah when I'm done here. In Idaho, statewide transformation of the system through the use of primary care medical homes, and you'll hear a little bit more detail about that as well in just a minute or two. Oregon, one of the other states, emphasizing capacity and improving service and sustainability, specifically in rural and frontier regions. Minnesota's accountable communities for health are throughout the state, including in rural sites, and the use of e-health. Grants to those ACHs, as well as e-health roadmaps. And I'll talk in a couple of minutes about their focus on emerging professions. And in Vermont, 61% of the population resides in federally defined rural regions, so clearly their statewide structural reforms affect rural. So the point of those two overview slides is, yes, this does matter, and yes, in the round one states, we are seeing rural inclusion. This slide gives you 4 themes that I'll cover one at a time in the following slides that are emerging from our overview of what are the activities in the innovation model states as they are rolling out. Remember, we're looking at states that are implementing what they develop. So these are implementation states. One of those themes is increasing system capacity. These are examples of that from the states. Arkansas promoted programs to increase recruitment and retention and promote adoption of new information technology, linking that up through their health information exchange so that you get the statewide impact of the new technology. In Minnesota, the Emerging Professions Integration Program, details to come in a couple slides. And in Vermont, funding improved clinical and claims data transmission, which obviously helps with new payment systems, integration analytics and modeling, and improved capacity to measure and address health workforce needs. So those are examples of increasing system capacity. Another theme is developing methodologies for financial risk sharing. In Arkansas, it's a retrospective payment for 13 episodes. We were not able to get at this point the detail on how they defined the 13. With gain sharing payments up to $3,000 and risk sharing up to $7,200, and they in 2014 implemented that across 654 episodes. Again, we're still searching and talking with them to get more detailed information. In Oregon, they're using 16 coordinated care organizations to implement alternative payment methodologies. And this goal of moving to pay for performance is language that shows up in at least 3 of the state innovation model testing sites. So this is clearly an example of financial risk sharing that they're moving toward. In Vermont, they're including commercial payers and Medicaid in the same shared savings accountable care organization model, and again, including pay for performance models, but we don't have the detail on what those models are. Another theme that emerged is use of primary care medical homes, or PCMH. Arkansas is moving heavily in that direction. That's the main thrust of what they're doing with the SIM award, and they're doing it in the Medicaid program. This does tie in with Arkansas's waiver that they received for expansion. So they've linked what they're doing with SIM with what they're doing under Medicaid expansion, reaching out as of 2014 to 70% of Medicaid enrollees, which exceeded their expected level for that first wave. Colorado is using integrated health homes, which is their version of PCMH. The interesting thing in Colorado is the use of community mental health centers as sites for integrated health homes. A little detail on one state, Idaho, and what they're doing with the PCMH approach. So they've built 180 of those as a goal. They're to reach level 1, and that's an NCQA technical level of recognition or accreditation. And they're underway with that. The goal is 180. They've got $30,000 out there in startup incentives to 60 at this point. The second goal in Idaho is to improve care coordination in real-time communication among those PCMHs. And the third goal is to support integration of those with another innovation they have underway in Idaho, and we don't have a lot of the detail on the other one, medical neighborhood. A fourth goal in Idaho is to improve patient access, and the interesting twist there that will be worth reading about as they move forward with this, and we have more evaluation reports coming out of Idaho, is this notion of supporting virtual PCMH model in the more remote locations where you can't staff up to what it takes to meet level 1 PCMH, but maybe you can do it virtually. So they've got an incentive payment out for that. And workforce-wise, they're training EMS and community workers to help meet the PCMH criteria along with the virtual telehealth connections they can put in. They're building a statewide system for collecting and analyzing quality and outcome data. And this is another one trying to transform the fee-for-service system to one that incentivizes value. They're in the early phase of that, so not much detail in terms of exactly how they're doing that yet. And finally, an evaluation goal of determining cost savings and return on investment from that model. The Colorado model is a program goal to transform primary care into integrated physical and behavioral. That's why the use of community health centers, mental health centers, is part of what's going on in Colorado. The goal is 80% of residents by 2019. Programs based on milestones from their framework for whole person care, and a goal for primary care practices across the state. First cohort in 2016 of 100, that's of the 400 that I mentioned earlier. And again, to repeat what I said earlier, and we actually have the list of 21 primary care practices that are part of what they're doing in the first cohort of this model. Oregon is another interesting case to look at a little bit of detail, and they've laid out cycles of activity in achieving the fourth theme of coordinated care. The first cycle is innovation and rapid learning, followed by then delivery, where you take what you've learned, obviously, and implement that through primary specialty behavioral and oral care. One interesting piece in Oregon is the integration of long-term care as part of what they're doing. There are only a couple of states out of this first round of 6 that did that. Excuse me. And then the third cycle is, again, the volume to value-based payment and budgets once you determine the innovation and the delivery mechanism. In Vermont, they're looking at care models for dually eligible residents, so another state that's paying attention to long-term supports and services as part of what they're doing to improve beneficiary service and outcomes. Minnesota is another interesting state to look at, again, in a little bit more detail. It's another one with the theme of coordinated care, that fourth theme. And these are their goals, that the majority of patients receive care that's patient-centered and coordinated. The providers participate in an accountable care organization or similar model to hold them accountable to the triple aim of lowering costs, better care, and better health. That communities, providers, and payers there have now begun to implement the new collaborative approaches to setting and achieving population health improvement goals. They're looking to select, support, and evaluate up to 15 of the community health groups. No, I've forgotten the acronym just that fast. Accountable community health. Encourage clinical and community partnerships, and determine whether these new ACHs in partnership with ACOs, love the alphabet soup, accountable communities for health. Thank you, Tracy. Determine whether those accountable communities for health in partnership with the ACOs result in improvements to quality, cost, and experience of care. They are in the implementation phase. They have up to 16 ACHs identified, and I know at least 13 are up and running right now. Some of the features of the Minnesota model is flexible risk for large integrated systems, but also scalable to smaller independent providers. Some of those 13 operating ACHs are in smaller counties aggregated into an ACH, and other partner organizations to ensure the broadest possible participation. They are working so far within the fee-for-service and managed care structure to allow faster implementation. Minnesota, as you may know, is a state with high penetration of managed care organizations already. So they get faster implementation timelines, least disruption to what everybody is already doing. They're aligning the payment models through the Medicaid program that is the SIM-supported program with what's going on in the commercial market and other emerging national models. They are also the state with next generation accountable care organizations and shared savings organizations. I know from our center's work, Wisconsin, Minnesota, Iowa are all heavily covered with Medicare ACOs. So in Minnesota, they're aligning the Medicare ACO with what they're doing through the SIM program with Medicaid, with what's already happening with firms like Alina on the provider side in the commercial market with ACO development in Minnesota. An update from them with 2015 numbers of where they are so far. 205,000 Medicaid beneficiaries receiving care through ACOs. They've identified $61.5 million in savings to date against a 2016 goal of $100 million. They achieved the goal of 15 ACHs by 2015. And they have 41% of fully insured Minnesotans are now covered by an ACO, or what in Minnesota is referred to as the total cost of care model, which is a model that includes not only health expenditures, but expenditures for social services. So they're well on their way to the 2016 goal of 60% Minnesotans covered by one of those models, ACO or total cost of care. So that's a summary of the information that we've been collecting as to what's happening. And in conclusion, I have a question for you. If this kind of information is valuable, should we continue to track this as best we can across the SIM states? Each state is doing it on their own. You can get some of the basic information from CMS and their website. As I said, though, even for the information that we've been able to collect so far, we had to go beyond CMS and the state websites to direct contacts. And the national report is really, the evaluation report is, frankly, it's difficult to use because of the length and detail that they're obligated to put into that. Rural people and providers are certainly part of the implementation of SIMS. I would expect that to continue with the round 2 states that include Colorado. As examples, Idaho, which we included in our summary here, New York, Ohio, Tennessee, Washington, Iowa here. All of those would have rural implications as well. In the future for the SIM program, as everything else in a day after an election is of course uncertain. It was started as a CMMI program. CMMI's origins go back to the ACA. So where this goes from here, your prediction is as good as mine, but we're certainly into year 2 of round 1 and year 1 of round 2. So there will be activity for the foreseeable future. We'll continue to track that, and if this is useful, continue to try to participate in webinars like this and get the documents posted to the ruralhealthvalue.org website, which probably appears as a URL on the next couple of slides. And sure enough, there it is. So I will turn this back over after that summary.
Thank you. Thank you, Keith. Are there any questions for Keith before we hear from Sarah in Colorado about the specifics of some of their efforts? Hearing none and seeing none, I will introduce Sarah Leahy, who is the Workforce and Clinic Program Manager at the Colorado Rural Health Center, Colorado State Office of Rural Health. Sarah manages the Colorado Provider Recruitment Program as well as the clinics program, which offers a large variety of services, including technical assistance to the vital part of Colorado's healthcare safety net. She's been working for CRHC, Colorado Rural Health Center, since 2007 and is proud of the work her program and the organization has done on behalf of rural Coloradans, and is excited to be part of the future endeavors with the organization. So join me in welcoming Sarah and thanking her for presenting on this. Star 2 to unmute your line, Sarah.
Thank you, Caleb. Can you hear me?
I can.
Perfect. Thanks for that introduction, Caleb, and thank you to TASC for inviting Colorado Rural Health Center and myself and giving us the opportunity to share a little bit more about what we are doing in Colorado. As Caleb mentioned, I work for the Colorado Rural Health Center, which serves as Colorado's Office of Rural Health, as well as our association for rural hospitals, clinics, and other healthcare facilities. We're here to share a little bit more about the work that we're doing with SIM, as well as our other internal quality improvement program and the collaborative efforts that we've had with other state partners in our state in regards to these two programs. So I'll start off and talk a little bit more about the work that we have been involved in specifically with our state innovation model. And it was helpful to have Keith kind of give that background about the state innovation model and how Colorado has been involved and some of the specific work that has come out of that. Like Keith mentioned, we are in round 2. And the way that we've set up the SIM model in our state may be unique to other states in the country. We are part of a program, an organization called the Colorado Health Extension System, or CHES, and this program has been running for many years now and has included different organizations all across the state that have a shared and vested interest in quality improvement. So they include association organizations, specific practices and hospitals, and other associations with members that may include hospitals or clinics in the state, all working on different quality improvement efforts. When the SIM opportunity arose, the Colorado Health Extension System decided to work as an entire organization to apply for the funding, and I went through our University of Colorado. So the CHES, once we were awarded the SIM program, we were broken out into different practice transformation organizations, which we call PTOs. And these are all those organizations that I have just mentioned. So organizations like ours, the State Office of Rural Health, the PCA, in our state, specific hospitals, specific practices, and other member organizations. And there are over 30 of these PTOs in the state. From there, we were able to apply to work with specific facilities, practices on the SIM model. So, in each of the PTOs, there can be an opportunity to be a practice facilitator, and our practice facilitators act as quality improvement coaches with each of the practices, as well as clinical health information technology advisors, or CHITAs. And the CHITAs act as folks to help exactly with that, with health information technology, helping the practices collect and analyze data and make sure that there are processes and workflows for them to get that data into their systems. So the entire state is covered as far as the SIM model. Practices, including both rural and urban practices, apply, and they can choose a practice transformation organization to work with. The Colorado Rural Health Center works with a small number of practices right now as both a PF and a CHITA facilitator. And I should mention that I'm joined by several of my team members here today that actually are doing most of the legwork with the SIM programs and the other quality improvement programs that we're working with. So I invite you to, if you have any questions, we're here along with my team to kind of answer any of the details about the program. But this is kind of a more high-level view of how we are collaborating within the state. One of the other big pieces of the SIM model that we're working on in Colorado is that we've been involved in efforts to organize different practices into EMR user groups. So this is something where different practices that have the same EMR vendors are able to have a venue to get together and share both best practices that they are using within their EMR as far as report writing and workflows, as well as challenges and barriers that they are facing with their EMR. And it gives those practices on those shared EMRs a larger voice, a shared voice together when speaking with vendors. And those vendors are also, the anticipation is that those vendors will also be invited to these user groups. One of the other ways that we are collaborating as a state with SIM is that the CHES organization and university facilitates different calls and webinars and venues, as well as including conferences and workshops for the different PTOs, the practice transformation organizations, to get together and share overall best practices and barriers around quality improvement and health information technology. And from there, I'm just going to open it up to any questions. If anyone has any questions about any of the specific efforts that we are working on in Colorado with unique practices. And there will be plenty of time at the end of this presentation as well.
This is Tracy Morton. I have a question regarding the EMR user groups. What are some of the biggest, I guess, opportunities that you're seeing so far as the different groups are coming together to collaborate? Any big kind of aha moments so far?
As far as opportunities, we have not seen much. We are currently in the phase of getting these groups together. So we actually haven't facilitated any of the user groups yet in our SIM collaboration. In the collaboration that I'm going to speak about following this, we have seen a few different outcomes come forth. And those include, one of them include different report writing tools and best practices, including workflows. So some of the clinics and the hospitals that are involved in that are able to kind of share reports as well as ways that they are, their providers and other users are entering data into those reports. And I'll hand it over to my team if there's anything else to add.
Yeah, that's basically it, right? At this point, that's what we're doing. We're just kind of facilitating the calls, getting the folks together who are using the specific EMRs, and just basically just kind of, you know, it's being a user group, it's their opportunity to collaborate amongst themselves as far as, you know, what's working, what's not, and then just documenting that and moving forward.
Is that helpful?
Yeah, it is.
And since these user groups are kind of just beginning, we are too kind of excited and interested to hear what the end results of them will be and what those outcomes are.
Sarah, I have one question in the chat from Yvonne. How many different EMRs does Colorado have, or and how many EHR user groups?
Well, there's quite a few different EMRs. Like I'm sure there's quite a few across the country. So I can't really specifically say exactly how many. I mean, we're working with folks that use NextGen, Athena, eClinicalWorks, GE, Greenway, Epic, Cerner. It just goes on and on. So it's kind of hard to actually kind of give a detailed number as far as that goes.
And that's just for our rural facilities in the state.
Yeah.
Thank you.
We have people on Healthland, and it's just there's a bunch out there, that's for sure.
Well, I would say that one of the challenges is that we have a small number of hospitals and clinics that may be the only EMR vendor that we are aware of in the state. So having them participate in a group is a little bit more difficult.